Thanks everyone for joining as we begin this conversation series. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Thank you, Lord, for blessing us with this day, for all the blessings you give to us individually and the blessings you give to our community at large. Thank you for the gifts of our speakers today, who you have blessed and going to bless our community by sharing their wisdom. May this section enlighten all of us. May He also equip us so that we continue to live fully and use the gifts you have given to us to serve each other. May we all be advanced in the knowledge we're going to learn in this section, so that in everything, glory will be given to your name. We offer these prayers as we present them to you in the name of the Father, and of the Son, and of the Holy Spirit. Amen. So go ahead.
Thank you, Father. Over to you, Dr. Bilo.
Okay. Thank you, Father James and Dr. Obinna, for welcoming us today to the conversation series. We have the opportunity of having two wonderful guest speakers today, who will be talking to us about, first of all, we have Dr. Nneka Chukwu, who will be talking to us about maternal health crisis, a call to action. And we also have Mrs. Nnenna Veronica Ofoegbu, who will be speaking to us about sickle cell education for young adults, all you need to know. So I'll start with introducing our first guest speaker for today, who's Dr. Nneka Chukwu. So Dr. Nneka Chukwu holds a doctoral degree in nursing with an emphasis in health care systems leadership. She has a master's degree in business administration and certification as an advanced nurse executive and a legal nurse consultant. She has over 20 years of experience in the healthcare industry and is currently the Director of Women and Children's Services at Emmanuel Medical Center. She's also an associate professor in the University of San Francisco Graduate Nursing Program. She's a published author, a mentor, a motivational speaker, and a seasoned leader. Dr. Chukwu brings along, and she belongs to several professional organizations, including the American College of Healthcare Executives, the National Society of Leadership and Success, the National Association of Nigerian Nurses in Northern California, or Northern America, sorry about that, the American Nurses Association, and the American Organization of Nursing Leaders. As an advocate for women and children, she's dedicated to bridging health equity gaps and community outreach programs aimed at addressing social determinants of health. Dr. Chukwu is actively involved in her local and church communities. She's a mother of 3 beautiful daughters and a son. In her leisure, she enjoys spending time with her children, singing, dancing, and reading. So just wanted to let everybody know that we are partnering today with Nnenna to bring you this conversation series. So I will pass it on to Dr. Nneka Chukwu. Welcome.
Thank you, Dr. Ngozi, so much for the introduction. I also thank you and Dr. Obinna for your efforts in making sure that we continue this conversation series. I also acknowledge the presence of our chaplain. So good evening, everybody, and thank you so much for joining us this evening as we explore these very important topics. Please let me know if you can see my screen.
We can see it.
Okay, so you can see the presentation?
If you can put it in presentation mode.
Sure, absolutely. Okay. All right, here we are. So for conflict of interest, I don't have any affiliations or financial involvement that conflict with the materials in this presentation. Also, this presentation is not intended to diagnose or treat medical conditions. I'll start the presentation with my why. Some of you already know my daughter, Chibuzo. For those who don't know her, this is Chibuzo. Chibuzo was born in 2005 at Kaiser Hayward, which is now Kaiser San Leandro. At the time when I was pregnant with her, I had just arrived to the United States a few months prior. So during the course of this pregnancy, I had gut-wrenching feelings that something was wrong. And I remember bringing those concerns up to the obstetrician who was assigned to me, and each time I was dismissed. So fast forward to 35 weeks later, I had Chibuzo prematurely. I also had a condition called severe preeclampsia. And Chibuzo was born with several conditions and complications, including ventricular septal defect, which was repaired when she was 3 months old. Chibuzo would never call me mom. She would never go to college. I also know that I cannot change what happened in the past, but I have an opportunity to make a difference for other women to ensure that they don't go through what I've had to go through and continue to go through with her. Okay, so what do we know? World Health Organization defined maternal mortality as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration of that pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So what this means is that, if a woman dies within 42 days, it's still considered maternal mortality related to pregnancy. According to the World Health Organization, African region accounted for 69% of all global maternal deaths in 2020. As you can see, that is quite alarming. And furthermore, we see here the countries with extremely high maternal mortality rates in Africa, Nigeria being one of them. So in 2017, we were reporting, by we, I mean Nigeria reported 917 deaths per 100,000 live births. And that number increased by nearly 14% in 2020 to reach 1,047 deaths. What we know also is that there's a lot of underreporting here because we don't have a standardized system in some of our in some parts of Africa, Nigeria specifically. So the deaths that occur in the rural areas are not accounted for. But it's also worth mentioning that other parts of the world experienced an increase in maternal mortality following the COVID pandemic. So here you can see, although the United States, the maternal mortality rate for United States is not as significant as that of Africa, as we saw previously, United States continues to have the highest mortality rate for maternal mortality rate, among developed countries in the world. So you can see on top there, United States at 23.8 out of 1,000 live births compared to the Netherlands, Australia, Japan, etc. Furthermore, Black women face more than double the average maternal mortality rate. So what you are looking at is a depiction of data collected between 2018 to 2021. And so you can see the red piece, which is non-Hispanic Black women. You can see the big gap between maternal mortality rate for Black women compared to that of others, so non-Hispanic white women as well as Hispanic women. And these data were extracted from CDC website. Okay, so then we break it down even further. Let's get to California to see what's happening in California. According to California Department of Public Health, CDC, the rate, CDPH, I'm sorry, the rate of pregnancy-related deaths for Black women in between 2015 and 2017 was 4.5 to 6 times higher than other groups. Although that number decreased between 2018 to 2022, you can see that it's still disproportionately higher for Black women at 3.1 to 3.4 compared to other people. What we know is that Black women constituted 45.8% deaths per 100,000 live births. Asian women was 15 deaths per 100,000. Hispanic and Latino women, 14.8. And for white women, it was 12.6 deaths per 100,000 live births. All right. So pregnant and postpartum Black women were also more than 2 times more likely than white women to die of postpartum hemorrhage, which is severe bleeding following a delivery, or embolism. We also know that Black women are more likely to die from cardiovascular disorders like preeclampsia compared to other women. And this is from Population Reference Bureau. Okay, so there was also another study conducted by Centers for Disease Control and Prevention, CDC, using data from 36 states that showed that 84% of all maternal deaths between 2017 to 2019 were preventable. And this is where the bulk of the issue lies. If they are preventable, why do we continue to lose our mothers? Okay, so let's have a little bit of fun with this particular question. Which of the facts below protect women from dying in pregnancy and childbirth? A, the level of education. B, income/social status. C, expertise in racial disparities. And you can post your answer in the chat. I'm just curious to know what you think. Okay. Okay. All right. Well, thank you so much for, thanks to those who participated. Amazing. Wow. Okay, I see several responses. Several people chose C, expertise in racial disparities. I also see some Bs, and I have A, level of education. Okay, that's for 2. And there's only one person who said none of the above, and that is actually the answer. None of the above. Not your level of education, not your income or social status, not even your expertise in racial disparities. And this is why that answer is the correct answer. So here we have Dr. Shalon Irvin, who held a BA in sociology, 2 master's degree, dual PhD. She was a lieutenant, and she also worked for CDC. She was involved also in health equity work, etc. Unfortunately, she died in 2017 from pregnancy-related complications. Like many others, she was dismissed by her provider or her providers, and her symptoms were disregarded. Unfortunately, we lost her a very intelligent, hardworking young woman. So in essence, our level of education and our involvement in this, this type of work has not been proven to save us. So according to this publication by New York City Health Department, women with more education, income, and wealth, of course, they tend to fare better in pregnancy. But Black women with college education in New York City were more than twice as likely to suffer severe complications from childbirth than white women without high school diploma. I'll let that sit for a little bit. In another study conducted between 2007 to 2016, they found that in California, Black mothers with highest incomes were more likely to have severe childbirth complications than white mothers with the lowest income. I'm going to share another story with you. Some years ago, I happened to go to the ER. I called 911 for a condition that I had and was taken to the ER via ambulance. And when I got there, the physician, the ED physician who came to see me, a white male physician, probably in his 40s, walked into the room, did not look at me, did not acknowledge me, and he made a comment to the nurse who was with him. Well, she's been to several EDs. I'm not giving her any narcotics today. We're just going to give her a GI cocktail and send her home. In that moment, my heart sank. Here was I, a nurse with a terminal degree and a lot of experience. I didn't dress like I was drug seeking or, I mean, like I lived on the streets, clearly. But to him, he only saw a collar. He only saw a Black person in a bed. He didn't see a human being. He saw a collar. He saw in his mind, this is a drug seeking Black woman who needed narcotics, and he wasn't going to give that to her. Needless to say that I ended up in the OR with an emergency surgery. And thankfully, I survived, right? But let's think about that for a minute. What if I could not advocate for myself? What if I didn't choose to speak up? What if I hadn't had an experience in the past involving being silenced? I could have died from that condition because it was that serious. So I went from the ER to the CT scan to the OR. So again, that clearly shows that our level of education, it doesn't matter what you attain, your social status, etc. When it comes to these issues, they don't keep us alive. So let's explore some of the leading causes or underlying causes of pregnancy-related death, according to CDC, and this publication is from 2022. Mental health conditions, which included deaths to suicide, overdosing, etc., related to substance use disorder, accounted for 23% of deaths. Then we have postpartum hemorrhage, otherwise known as excessive bleeding, which accounted for 14%. Cardiac conditions accounted for 13%. Infections, 9%. Type of blood clot, 9%. Cardiomyopathy, 9%. And of course, hypertensive disorders of pregnancy accounted for 7% of these deaths. So among pregnancy-related deaths with information on timing, because timing is also important for proper documentation, what we found based on previous research was that the deaths of our Black mothers were miscoded, right? From the timing to the cause of death, etc. So, but based on information on timing, they found that 22% of deaths occurred during pregnancy, 25% occurred on the day of delivery or within 7 days following delivery. And then you have the 53% that occurred between 7 days to 1 year after pregnancy. Again, this shows that, you know, there's some misconception that once the baby is out, the danger period is over. And that's actually not true. So you can see from this that we have a very high percentage of deaths that are occurring between 7 days to 1 year following pregnancy. Other things that contribute to this type of poor outcome for our Black mothers, we're going to look at some historical factors, right? So what you're looking at currently is below you see a Black pregnant mother, and on top of the illustration page, you can see a pregnant white mother. Notice that the path, their journey is very different. So there are historical factors that have continued to influence the outcomes of care for our Black mothers, from racism to poverty, etc. And so when we go over some of these causes of deaths, the question is it race or is it racism? What actually contributes to this type of the significant disparities that we see in maternal child health? Why are our Black mothers continuing to die? We also know that there's a lot of mistrust when it comes to going to the hospital and trust in healthcare providers. We see a lot of mistrust amongst our Black mothers for obvious reasons. I mean, if you're going to be dismissed, if nobody is going to listen to your concerns, sometimes when our Black men go accompany their significant other to the hospital, they are labeled as being aggressive, right? When in fact, all they want to do is advocate for their family members. So they are treated in a way that shows, okay, in some cases, oh, we're going to have to call security for this person. Why would you call security? They are trying to advocate for their family members. Again, is it race or is it racism? Moving us along. So when we think about equity versus equality, right? We hear things like, well, everybody gets treated the same way. The reality is, it's not a one-size-shoe-fits-all. Needs may be different from the needs of the next person. And so if we're treating everybody the same way, we will not be able to provide specific care, unique care to the various population that we serve. And so our goal is equity, not equality. So the mom who has to take 3 buses to get her to her appointment should not have the first appointment of the day. And so we factor in all the challenges: poverty, where do they live, their knowledge, skill set, education. Every care should be tailored to the unique needs of the population or the patients that we serve. And so we are rooting and really working so hard towards making sure that the care we provide is equitable. Other factors, we have the mother blame, right? And so in this comment by Dr. Arvin's friend, who happened to be a medical director for Planned Parenthood, said, you can't educate your way out of this problem. You can't healthcare access your way out of this problem. There's something inherently wrong with the system that's not valuing the lives of Black women equally to white women. And don't get me wrong, I'm not suggesting that our white mothers should die. Nobody should die from complications of pregnancy when it's preventable. It remains that our Black mothers are not receiving the same type of treatment, the same level of care like our white mothers. In another comment, Neil Shah, who's an obstetrician, said, the common thread is that when Black women expressed concern about their symptoms, clinicians were more delayed and seemed to believe them less. You can also see that from the story that I shared with you, but when I was pregnant with my daughter Chibuzo, as well as when I visited the ED for another health related issue. We're dismissed. And when you're dismissed, that ultimately leads to delay in care. Well, it's normal for you to have that type of pain after a C-section. I'm not concerned about the blood pressure. I mean, your type of people have high blood pressure anyway. Again, is it race or is it racism? There are also other instances where the mother is blamed. Maybe she's on drugs, or maybe she didn't have prenatal care. Is it that, or is there something else that is wrong with our system? I love this quote so much. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And this is by Martin Luther King Jr. Let that sit for a little bit. Should there ever be a time when there's injustice in healthcare? I mean, our doctors take an oath, nurses take an oath. We promise to safeguard the lives of those who come to us. So what is going on? And why do we continue to see the same outcomes over and over and over again? So now what? Now that we know, we've heard all this, we've seen the data, we've seen the research, we've seen the challenges, etc. What are we going to do with all the information that we have? And so there's a call to action, which is why we're on this call today, right? No woman should die from preventable outcomes while given life. No one. We know that pregnancy is not a disease, especially from death from preventable outcomes. Pregnancy is not a disease. And we also know that maternal mortality has a significant impact on the families, on our communities, on the society at large. The outcomes not only impact the immediate family. So here we have children who are being raised without their mothers, spouses without their significant other, parents who lose their children to preventable outcomes. And so there's a call to action for all of us to do something about this. And so what we're going to do is that we're going to use improvement science and evidence-based practice to eliminate preventable, underline the word preventable. The goal is not to cure world hunger. I know we cannot boil the ocean, but we can start somewhere, right? So focus on the preventable causes of morbidity and mortality at the international level, at the national level, at the state level, and also at the local and community levels. There's so much work that needs to be done. And so at the international level, what here are pictures that were taken when I went home to implement a project. And as USF, following their motto, it says, let's change the world from here. And so I decided to embark on a journey to change the world from here and implemented a simulation-based training for student midwives and registered nurse midwives at the Holy Rosary Hospital, Emekuku in Nigeria. And that experience was mind-blowing, to say the least. Over time, we believe that lack of resources is the major problem. But what I've found during this process is that there's a big gap, a knowledge gap, knowledge deficit among our providers when it comes to proactively managing pregnancy, taking care of our patients, and also managing some of the complications that can arise during the labor process. So we have a lot of work to do. So if anyone on this call is interested in partnering, there are so many groups out there. I am also up for another mission, but we have so much to do for our home country, Nigeria, as well as here in the United States. So what's happening at the federal level? In 2021, Kamala Harris announced call to action to reduce maternal mortality and morbidity. What came out of that is that Energy and Commerce Committee Build Back Better Act legislation, and they have invested so much and enacted an act to save mothers' lives, end racial and ethnic maternal health disparities, as well as advance birth equity across the United States. We don't want this to just be one of those acts, we want it to be meaningful. We want our mothers to benefit from all these efforts to improve outcomes of care. The Momnibus also takes action through historic investments that address every driver of maternal mortality. And the caucus has enacted over 200 million in Momnibus funding. Moving us right along, in California, at the state level, SB 464, the California Dignity in Pregnancy and Childbirth Act, went into effect on January 1st, 2020. And so for those of you who work in obstetrics, I hope that your organization implemented this, right? And this requires all healthcare providers who work in obstetrics. And quite frankly, some organizations include those who work in their neonatologists and those who work in the NICU, to make sure that everybody gets trained on implicit bias, to make sure they understand the impact of implicit bias on the care that we provide to our patients. Part of the work under this act also is access to prenatal care, considering socioeconomic status, etc. And the intent is to reduce effects of implicit bias in pregnancy and childbirth. So at the local level, again, I am so happy that we have this opportunity, and thanks to the Nigerian Igbo Catholic Community of San Jose for providing us this platform. Really, conversation is where it begins. It starts with us talking to each other, talking about this, getting comfortable, being uncomfortable, because yes, when we talk about race and racism and the way that it impacts the care that we provide and the lives of our patients, it is uncomfortable. We recognize that. However, that is something that needs to happen. There needs to be increased collaboration between healthcare agencies and local communities, just like what we are doing currently. We need to participate in outreach programs, find out what's available in your area. Some years ago, when I worked for one of the Kaisers, I helped to implement a program where we brought our patients together for them to help us design care. As healthcare providers, yes, we're very knowledgeable. We know what needs to happen, but we need to take it even further. Let's get our patients involved in the conversation. And so the goal or the aim of that group, Maternal Child Health Advisory Council, was to have different mothers from different ethnic groups participate. And so if you have a Hispanic mother at the table, she understands that she's not representing herself. She's representing Hispanic moms. The Black mother who's sitting at the table is not representing herself. She is representing her community. And through that process, we can see how and what we can do to make her better. And one thing that I learned, one thing that was really powerful for me was, we were struggling with improving a breastfeeding rate for our Black mothers. It didn't matter what was tried. It wasn't just going anywhere. So one of the women who was part of the council said, you do realize that there is a component of slavery that continues to influence this. And my eyes were like, okay, tell me more, right? And so during slavery, Black women were forced to breastfeed the children of their white, what's the word that I'm looking for? Their mistresses, they were forced to breastfeed their babies. And so that ingrained in them affected their ability to breastfeed. So over the years, it has been passed down from generation to generation. I wouldn't have known that if she wasn't part of the council, right? So that is a powerful way of getting our community engaged in a conversation. Know your risk factors. It is important for us to know our bodies, know our risk factors going in. Use your voice. Do not allow anyone to silence your voice. Ask questions. When you have that gut-wrenching feeling that something is not right, it doesn't feel right, something is wrong, please speak up. Seek second and third opinion. Don't stop. Don't let anybody tell you, yeah, it's okay, we can take a look at it next week. No, the time is now. We need to take action. We need to own it. And so in summary, we know that despite advancements in healthcare, maternal mortality and morbidity continue to be a global problem. Black women are more likely to die from pregnancy-related complications than our white women. We also know that implicit bias is a key cause that drives health disparities in communities of color. And the time for change is now. I hope that we're not going to continue to sit on the sideline. I hope you're going to take action. I hope you will choose to join the movement. Thank you so much.
Awesome. Well, thank you so much, Dr. Nneka, for that. We are going to continue, and then we will have questions at the end. So I would like to introduce to you Mrs. Nneka. Sorry. All right, hold on one second. Sorry about that. I would like to introduce to you Mrs. Nnenna Veronica Ofoegbu. Mrs. Nnenna is a registered nurse. She's worked for 16 years as a registered nurse. She currently works at Kaiser Permanente in Roseville, California. She works in the med-surg unit, focusing on inpatient care for adults with cardiovascular disease and acute stroke. Nnenna completed her Bachelor's of Science in Nursing and her Master's of Science in Nursing Education at Holy Names University. While completing her MSN-ED, Nnenna was inducted into the Sigma Theta Tau International Honors Society, NICCSJ chapter. She's passionate about reducing health disparities through patient education and improving communication between patients and healthcare providers. Nnenna was a member of the Patient Care Experience Committee at Kaiser Permanente in Roseville and facilitated the implementation of the Warm Swarm, a method of welcoming patients in a welcoming, informative, and efficient manner. Nnenna is a proud mother of 4 children and a grandmother of 1 child. So please join me in welcoming Mrs. Nnenna Ofoegbu to today's conversation around sickle cell education. Welcome.
Thank you. Thank you, Dr. Ngozi-Obilo. Thank you, everybody on the panel. Thank you for giving me the opportunity to present on sickle cell disease. Just as an information, this topic is actually new to me. I have come across it through my education, but not much of a detail. Let me see, I'm going to share. Okay, can you see?
Yes.
Okay.
Yes, if you put it on presentation for.
Okay, let me see. Sorry. So this topic, sickle cell, is huge. Never come across it in these details, so it's just going to be small information because it's a lot of details in it. So learning objectives, we're going to go through the introduction, what is sickle cell, pathophysiology, presence, prevalence of sickle cell, signs and symptoms, complications of sickle cell. Treatments and managements of sickle cell disease, diagnosis, impacts of sickle cell on patients, and advice in conclusion. So what is sickle cell? Sickle cell disease, also called sickle cell anemia, comprises of abnormal recessive allele. It is an inherited homozygous S gene blood cell disorder that affects the hemoglobin, a protein that carries oxygen throughout the body. For a person to have sickle cell disease, they must inherit the S gene from both parents at the time of conception, if both parents are carriers. Everyone inherits a hemoglobin gene from each parent. We do have potential for hemoglobin AA. That's the normal gene type. There is no sickle cell disease. And hemoglobin AS, that's the sickle cell gene carrier, but there's no sickle cell disease. The hemoglobin SS, that's when a person picks up S gene from both parents, they end up with hemoglobin SS, which is sickle cell disease. So this person is called, they have sickle cell disease or they have sickle cell anemia. So with each conception, a couple with sickle cell trait, which is hemoglobin AS, would have chances of having offspring with 25% chances of having offspring with hemoglobin SS. 25% chances of having hemoglobin AA, which is the normal adult hemoglobin. And 50% chances of having a child with hemoglobin AS, which is the hemoglobin, which is the sickle cell trait. So the sickle cell disease is hereditary disease. Millions of people live with globally. Sickle cell disease is more common in people with ancestors from sub-Saharan Africa, as well as in people from Hispanic, Mediterranean, East India, and Middle Eastern ancestry in the historically malaria endemic region. In sickle cell disease, the abnormal hemoglobin S replaces the normal hemoglobin A. This replacement leads to abnormal function of the red blood cell. It is characterized as the hemoglobin S. Hemoglobin A, the normal adult hemoglobin, carries oxygen from the lungs and facilitates removal of carbon dioxide. It carries 2 alpha chains and 2 beta chains of amino acid. This allows for increased oxygen carrying capacity in the red blood cell. We also have hemoglobin F, or the fetal hemoglobin. Babies are born instead of the S hemoglobin. When they are born with sickle cell, they have advantage to this F hemoglobin. This F hemoglobin carries 2 alpha chains and 2 glutamine chain. For the first 6 months of life, infants are protected with large level of hemoglobin F. Symptoms of sickle cell may start to manifest thereafter as the hemoglobin F is replaced with hemoglobin S. So the little history of sickle cell disease. Sickle cell blood mutation originated thousands of years ago in hemoglobin molecule to change the shape and to protect us from the mosquito parasite from affecting us. In 1910, first discovery was made in Western medicine on sickle cell disease when hematology was integrated as specialty in Western medicine. In 1957, causes of sickle cell was determined to be a disorder in hemoglobin molecule. So what does sickle cell blood cell look like? The normal red blood cells are rounded, biconcaved, shaped like donuts, flexible, and flows through the capillaries with ease. The life cycle is up to 120 days. Then newer red blood cells are made from the bone marrow to replace the old dead cells. However, the sickle blood cell has a crescent shape and is rigid, and it clumps together. It causes causing occlusions and preventing proper circulation in the capillaries. The life cycle of sickle cell blood is 10 to 20 days. The bone marrow is working fast to meet up with high demand for new red cells. What does this mean? So the new red blood cells are frequently made in our bone marrow, and it takes about 120 for the life cycle of normal red blood cell. So as a result of that, the bone marrow is regulated by making as needed. But with the sickle cell, the breakdown of the sickle cell blood is fast. It's super fast. It's just about 2 weeks or so, whereas the normal cycle of the normal red blood cell is about 4 months. So with that, the bone marrow that is responsible in making the new red blood cells get weakened and diseased, and as well as organs that are responsible in cleaning out the old recycled red blood cell. They get weakened and diseased. So prevalence of sickle cell, studies show that 4.4 million people have sickle cell disease worldwide. However, more of the burden is in sub-Saharan African region. About 80% of sickle cell disease occurs in sub-Saharan Africa. A critical review of studies suggests Nigeria has the largest population of persons affected with sickle cell disease globally. So sickle cell disease affects approximately 100,000 Americans. With this, the sickle cell disease occurs among about 1 out of every 365 Blacks or African American birth. Now, sickle cell disease also occurs among about 1 out of every 16,300 Hispanics, Hispanic American birth. About 1 in 13 Black or African American babies is born with sickle cell trait. Okay, so the pathophysiology of hemoglobin S is as a result of mutation, substituting thymine from adenine in the 6th position of chromosome 11 within the 17th nucleotide at the beta chain. Gene GAG changed to gene GTG. This results in glutamic acid change to coding of valine, which is hydrophobic, instead of glutamate in position 6 of the beta chain. The result of valine leads to abnormal hemoglobin S, which produces severe health problems. Under a low oxygen or stressful condition, hemoglobin S changes from a normal round shape to a crescent, loose flexibilities, struggles to pass through tiny capillaries, and fragile. It loses capacity to carry oxygen molecules. These changes lead to acute and chronic complications throughout the body, like a vicious cycle. As more sickling is ongoing, it results in low blood level, low oxygen, and more sickling, because the more we have low oxygen condition, it causes more of the sickling happening. The only remedy is to go to the hospital. We'll come to the treatment and management. So the main causes of pathophysiology of sickle cell disease is acute vasoocclusion within acute vasoocclusion, which leads to both acute and chronic episodes of pain due to lack of tissue perfusion, leading to tissue death. These painful episodes are considered considered a crisis and requires hospitalization. Frequency of crisis may vary individual. Some may experience acute vasoocclusion as many as 6 times or more annually, while others may be much less or none. Triggers of vasoocclusion crisis includes low oxygen condition, dehydration, changes in body temperatures, and stressful events like physical exercise. Anything resulting in less oxygen in the body will result to sickling. This may trigger a release of cytokine reactions in the body, which may lead to vasoocclusion crisis. So when we have vasoocclusion crisis, it's not just destroy the red blood cells sickling. It triggers inflammatory reaction, which brings in other blood products like platelets and neutrophils and those things that comes into mitigate with what is going on at the site, called which causes a lot of fluid that is sticky and clumpy and prevents proper circulation. So when hemoglobin S sickles, it breaks apart and dies easily. New blood cells are produced from the bone marrow to replace the destroyed cells. The spleen cleans out the old and destroyed blood cells, this cycle repeats itself more frequently than normal, which leads to organ burnout. So this is example of what happens throughout the body when we have these cycle episodes of sickling throughout the body. Like in the brain, we have meningitis, strokes even in children as young as 3 years. We have in the cardiovascular, young children can end up with congestive heart failure, cardiomegaly, and conditions as such. On the bone, we have bone marrow infarction, where the bone start having infection, osteomyelitis, and so on and so forth. Is a whole lot. In the spleen, which is the major organ that helps to protect from infection, encapsulated bacteria. So now the spleen is working so hard to clean out the, remove the dead red blood cells. The spleen end up having what they call spleen sequestration. It swells up, it gets inflamed, and in some cases, from this chronically having pain crisis and the sickling, the patient actually lose the use of their spleen. If you do X-ray or ultrasound, there will be no spleen, even though the spleen is there, but the function is no longer there. So it's a very complicated condition. In the lungs, frequently having pneumonia. In the eye, frequently having eye problems, like glaucoma in young ones. Okay. So signs and symptoms. Pain is usually generalized. Sometimes is in a specific part of the body, but much of the time they come in, they will tell you is all over. And we do have pain assessment scale that is used to rate the rate of the pain. There is the smiling face to use when the person is not able to verbalize, but the 0 to 10 scale helps to rate how severe, to be able to give the appropriate amount of medication, because the goal is to stop the pain. The pain, once the pain is down, it will start to reverse. When the patient comes in sooner, as they start having the crisis, there's chances to reverse some of the sickled blood cells back to normal. But once it has taken longer, it's no longer able to be reversed. So anemia being one of the big issues, most of the patients have anemia. Their blood level tend to be low. They tend to live normal with low blood level. You will see that their skin is pale. They tend to be very tired, fatigued, and very difficult for them to do so much. Their activity intolerance, they tend to get tired when they run a very short distance. The yellowing of the eyes will be noticed if there is high number of bilirubin from broken down of the red blood cells. You have so much bilirubin. The liver tends to be the one that helps to convert the bilirubin to other use, but the liver is working so hard. Basically, all the organs are worn out from doing so much chores. The urine also shows urine not being concentrated in the kidney, also shows that the kidney is also struggling. They tend to pee a lot when the kidney is not able to concentrate urine. And peeing so much will mean dehydration. They easily get dehydrated. So they also have frequent infection. Why? Because the organ that is responsible in keeping us from getting some of those encapsulated bacteria is also weak. It's not able to do some of those services. Like I mentioned, the spleen gets really, some of the patients doesn't even have functioning spleen at all from very young age. That's why they tend to have frequent infection. And chest pain sometimes they come in, but it is related to the lungs. They call it chest, what is it called? Yeah, it tend to cause chest pain when the lungs is involved with vaso-occlusion, and there is infiltration noticed in the X-ray, which means the lungs has some fluid in the alveoli that helps us to hold oxygen in exchange with carbon dioxide. There's no more enough space to hold oxygen. That causes, it comes across as chest pain. And that can be life-threatening. Okay, abdominal pain. A lot of things can be happening in the abdomen that can cause abdominal pain. Shortness of breath, shallow, fast breathing, tachypnea, wheezing, audible wheezing, cough, which may contain blood, fever. So these patients comes in very sick. You may not even look at them and say, yes, you have this much pain, because they are so much lived with pain. They are so much used to high pain, but when they come in, they are in very severe pain. You may not look at them and say, and compare it to what their pain level they are reporting. So acute pain crisis and complications. So the sickle cell patient commonly present to the emergency room with sudden and severe pain, acute in nature due to vaso-occlusion crisis, to differentiate, to different parts of the body. I have a few pictures here just to show example of some of the conditions. This is the lungs. The lungs is filled with fluid, which can be seen in X-ray. And the vaso-occlusion, you can see how the clumping of the red blood cell blocks off circulation. And the part of the body that is not getting circulation is going to start having all kinds of issues. Okay, so the painful swelling of hands and feet is usually found in infants. It's called dactylitis. The acute chest syndrome, that's what I was thinking. The acute chest syndrome is also found in children and adults. That's the one that can be life-threatening. Pretty much everything happening to sickle cell patients can be life-threatening. The spleen sequestration is due to repeat sickling. Blood is trapped and causing severe anemia and abdominal pain. Priapism is found in male patients. Is a prolonged painful erection due to vaso-occlusion. They could stay erected for days. It requires hospital emergency. Bone marrow, bone pain due to bone marrow infarction, because the bone marrow is frequently making so much new red blood cells, and that it gets weakened, and it does not even have enough energy, and it can end up having infarction, which is more like losing the life of the bone marrow. The avascular necrosis of the femoral head is due to avascular occlusion, which is it is not because this person had a fall, it's not because they had an infection. Avascular is because the head of the femur tend to have less circulation around it, and it gets it necrotizes and dies. And if you have observed some sickle cell patients, they tend to limp. They limp because of the hip. They tend to have hip problem. Strokes can be found in also young children. Okay, example of treatments and management. There are so many. I can only mention a few. So pain medications in the hospital, they start with analgesics like morphine or hydromorphone. Some of these patients are already taking opioid medications at home, the strong opioid medications. So when they come in, they will need to have something stronger than what they have been taking. They also use NSAIDs like Motrins, Tylenols, and stuff like that. And oxygen is also given when needed. IV fluid is also given. Antibiotics is given with if the patient has infection going. Blood transfusion is often done if the patient has symptoms of anemia, symptoms of low blood level. Patients like this live on low blood level. Even they can come in with 7 points. It's not going to be transfused. Transfusion also is given if the patient has to go on some surgery. The goal for the level of blood before surgery tend to be about 10 to give it more cushion. Bone marrow transplant is a cure that is available at this time. It's still under research, but is done to some of the patients that has so much problems with crisis. The process of bone marrow transplant is long. It could take 4 months. They have to go through a lot of preparations, such as doing having to go through a chemotherapy, radiation therapy, and so many. So long time spent in the hospital to prepare for bone marrow, and the bone marrow has to be from a good match. Better if it's from a sibling. So hydroxyurea is a medication approved by FDA. Is given to reduce the sickling. It is shown to have 32% in reduction of sickling. The L-glutamine also helps to reduce the reduce vaso-occlusions. It shows effectiveness of 25%. Now, crystallizumab is another medication, has about 45% in reduction of vaso-occlusion. Heparin is a medication given, is a blood thinner. When the patient comes with vaso-occlusion, the circulation is disrupted. The heparin helps to loosen the blood level, to loosen the blood consistency, to make it easier for freer movement of circulation. So the prophylactically, they give penicillin V to children under 5 to prevent frequent infection. Vaccination is also provided to protect against pneumococcal pneumonia, Haemophilus influenza, meningococcal, and Hep B and influenza virus. So they have to have these as protection. Normally, pneumonia vaccine is given to adults ages 60, but this is given to young children because of their condition. Okay, so every 1 to 2 years, children age of 2 to 16 are monitored for stroke by doing transcranial Doppler ultrasound. Sometimes stroke can be the first manifestation of symptom in children. When they come in, they are not responsive. That's when the parents bring them in and they are found to have stroke. So they are routinely monitored for stroke. Fundus exam starting at age 10 is done to monitor for retinopathy, for eye damage. So the advice is for people with sickle cell disease to stay clear around large crowd, people who are sick, and stay hydrated and seek medical help promptly. So how do we diagnose this condition? Prenatally, they check PCR, polymerase chain reaction, is checked to test for the DNA-based test, the allele-specific hybridization, chorionic village sampling, CVS, and amniocentesis can be done before the child is delivered. Postnatally, sickle cell screening is done. This includes blood tests, CBC, with differential reticulocytes count. Reticulocyte count is the number of new red blood cells made from the bone marrow periodically, because it has a level that is normal. When you have the excess amount, it shows that something else is going on. Okay. Hemoglobin soluble test, hemoglobin electrophoresis, kidney function test, liver function tests. Hepatobiliary function test, CSF, that's cerebral spinal fluid examination for clinical symptoms related to neurologic conditions like stroke or meningitis. When a patient comes in with neck stiffness, positive Brunziski-Canine signs, this is usually found in children, young infants. Okay, so in 2006, newborn mandatory screening in all 50 states of the United States were established. Radiography includes for diagnosis, they check for chest X-ray, to check for the lungs or other parts of the body, ultrasound for possible clots. They tend to have blood clots or fat embolisms from the bone marrow. MRIs, CT scans, echocardiogram to check the cardiovascular function. Impacts of sickle cell disease on patients and family. Sickle cell disease is a serious and lifelong health condition. Most patients started their painful experience as early as 3 months old. Frequent hospitalization and having to stay admitted for three days to 3 weeks at a time. Their family members must be with them at all times, considering their young age. Their childhood activities and school attendances are often interrupted due to this condition of frequent acute pain crisis and long hospital stays. Sometimes it is difficult to hold down a job schedule for the adult patients. Poor families may find it difficult to afford medical treatment, and so you find them going to the ER, the emergency room, whenever they need medical care. They are often labeled frequent flyers. And so, I'm sorry. They are often labeled frequent flyers and or attention medication seeking. It is advised that the patients go to the hospital when they are experiencing pain crisis, but some patients shy away from being labeled until the pain is too much to bear. In conclusion, knowledge is power. We need to make greater effort to educate the public to understand the devastating effects of sickle cell disease and how it's preventable. The importance of premarital sickle cell gene screening as a prevention of having a child with sickle cell disease. Knowing the signs and symptoms of sickle cell disease and taking quick action can save lives. We all have the power to advocate for our families and communities in our own special way. More fundings for awareness and easy access to medical treatment is needed. Newborn screening as a global universal practice and follow up with early interventions for every sickle cell patient. Thank you all. And this month, September, is the Sickle Cell Awareness Month. Okay.
Thank you. Very nice. Thank you so much for such a wonderful presentation.
Thank you.
Very nice. Very, very educating, and we learned a lot. So we're gonna open it up for questions. You can either put your questions on the chat. If you are going to raise your hands, please make your question very brief, because we don't have so much time left. Thank you. If not, I do have some questions, but I want to open it up to the audience first.
How do I go back? How do I stop sharing?
Let's see. Okay.
On the top right-hand corner of your screen, you'll see.
Top right hand.
Yes, or top left. The red box that shows share.
Yeah, why it says share.
Okay.
I think it'll be to your left.
Okay. Stop sharing.
It's a green button at the bottom that says share.
Uh-huh.
So when you light that up, you're gonna see where it says end.
End. Okay. Okay.
You see it?
Oh, yeah.
No worries. Any questions? The audience? Okay, Dr. Binna, I see your hands up.
Yes, but I think I have two questions for each of the presenters. And I have to start with saying thank you for the wonderful presentation. I think, first of all, to Dr. Nneka, I think one of the key takeaways or advice or recommendation that she made was that we should advocate for ourselves and for as patients and even for our families when they are receiving health care. And it's easier for somebody who is in the healthcare profession to say advocate. For somebody who is not in the healthcare profession, I think it wouldn't sound, it's not as easy as it sounds. And I'm curious to know, what are some of the tips you might have for somebody who is not in the healthcare on how to go about advocating for themselves or their family, particularly for Black men who are easily labeled as being aggressive. So how do you do that?
Great question, Dr. Obi. And that is a real challenge. It is a real problem. Within our culture, we have there's this notion that you don't have to tell people what you're going through, right? We keep it all secret because we want to protect our privacy, and that's okay, right? But then it shouldn't be to the detriment, at our own detriment, right? And so by that, I mean, there are people within our communities who have the knowledge. So for example, if you're going through a process or a challenge and you're not sure how to go about advocating, it's okay to reach out to someone. So I'll say start with identifying who your resources are and the people within your network who may have the knowledge that you seek, and collaborate with them. Because the reality is, whatever someone else has gone through that. And for us who work in a hospital, we have seen a lot of scenarios, a lot of cases, right? And we've also had our personal challenges. So I'll say start by reaching out and asking the right questions. Seek to understand.
Thank you. And my next question is for Mrs. Ofoegbu. When you talk about the topic of sickle cell, what comes to mind for me kind of people who are our young adults who are about getting married, looking for life partners. And what advice do you have for them in terms of what should they be aware of? When should they do the check? You know, what questions should they ask? This kind of thing. What should they be looking for? Because, you know, from experience, it's difficult to navigate that situation when you're already head over heels in love. What's your advice for them? You know.
Okay. So I I mentioned it in my conclusion as part of ways to prevent having children with this condition. A person with the sickle cell trait can safely have children with a person that did not have sickle cell trait, did not have sickle cell anemia. They have normal gene, which is the gene AA, genotype AA. So genotype AS and genotype AS can potentially have a child with SS, which causes the sickle cell disease. The advice and the knowledge we all should take home and also provide this to everybody we know is to make sure to check both couple for their genotype. It's not the blood type, it's called genotype. Are they AA? Are they AS? Are they SS? There's another one called SC. It's also sickle cell disease, but they're saying that it's less severe. But anything that affects the blood circulation would cause a difficult livelihood for anybody. So the thing is to check before you start having children. I myself, I don't know my genotype. I did not check it before I got married. And my husband, I don't think he knows. So I think a whole lot of us did not know that. So it's something maybe needed to be brought up to the school or to church, where most of us are beginning, can easily get that information and make better use of that information. That's the only way to protect from having children with sickle cell disease.
Thank you so much, Nnenna, for responding to those questions. I see a couple of other hands up, and I'll start with Dr. Agateke.
Thank you so much, Dr. Bilo, and thank you to my colleagues, Dr. Chukwu and Nnenna, for sharing this knowledge. In fact, that's the question somebody just asked is what we were thinking about this sickle cell when we did this topic in our Lunch and Learn in May for Nurses Week. We understand our young adults are very curious, very educated members of the community. And we were thinking that if we begin to hold this discussion, just float the ideas to them, I believe they will do the research and find out even more to protect themselves. Myself, we have a family friend who lost a daughter at 28 because of sickle cell. So it's a very preventable thing based on knowledge and decision making. And we were thinking our young adults are capable of making these kind of decisions as soon as we can call their attention to these issues. As Dr. Nneka pointed out, we have to be responsible for our health in our community because for a long time, that has been either proactively denied or unintentionally denied. But many of us are now, at least we have some knowledge, which is why we were very eager to collaborate with the Igbo Catholic to bring this knowledge to at least the few that is here to move it forward wherever we can do so. So I really do appreciate your presentation and thank you for giving us the opportunity to also have this platform to present. Thank you. Oh, and in terms of knowing how to ask health questions, in fact, the Joint Commission is aware of this. It's not just us. Many of the cultural people from different cultures have similar issues. So if you go on the website, there is an acronym that says speak up. Is the one word that says speak up. This is how we educate the patients to advocate for themselves. So that's a good place to start to learn how to do so, the right way to ask questions. In fact, you can write them down and hand it over to the provider, but we must insist because it's our health at stake. Thank you.
Thank you so much, Dr. Agata. I'll move on to Dr. Mercy Ebujo. Are you able to unmute yourself? No?
Okay.
Okay, good. We can hear you.
Can you hear me now?
Yes.
Okay, I sound like the commercial. Thank you. Thank you, Dr. Nneka and Nnenna for the presentation. Well, it was very informative. Mine, one of it is actually a comment for those who live here in Santa Clara County. The Santa Clara County has the Black Infant Health Program. It's a program that follows pregnant and parenting women from the age when you're pregnant until 2 years of life of your child. What they do is education. They help to advocate for you. They can go, is actually through the public health department. And is a state-funded program that run by the public health. The public health nurses can go with you to your doctor's appointments if you feel like you're not getting the right responses from your doctors or they're not treating you right. The goal of the program is to prevent early premature babies, and also to make sure that women do not die during the process of from pregnancy through postpartum. So that's why they go through the whole 2 years of the baby's life. And also they make sure that they take their children to get all these testings done and all that. I worked with that program. That was when I was in public health. That was my job as a public health nurse, about 5 years. And I never had any patient who's from Nigeria. I had a couple of them from like Ethiopia and Somalia and Sudan, but I never had anybody that was from Nigeria. And we did home visits. I did education with them in the office. They come to the office. We have group classes. So I think, like Dr. Nneka said, nothing, not your money, not your education, not your social economic background really excludes you from this what I call horror show sometimes that befalls Black women, regardless of who you are. But we should take advantage of that. So any pregnant woman and you feel like you're not getting this, and just look up Black Infant Health Program. This one is for Santa Clara County. It's also a statewide program, is everywhere. So that's one way to try to advocate for yourself, because they can help you. They'll make home visits to your home until your child is 2 years old. And also for Nnenna, well presented as well. For the sickle cell, what we can do as parents of young men and women is that we need to encourage them to get tested. There is no shame or risk in getting tested. Back home, we have so many families that the children die one after the other, one after the other, one after the other, because of sickle cell. Once they have that sickle cell, they don't have the medications that the ones that Nnenna mentioned here. They don't have the money to go through IV every few weeks. They do die. And most of them will die before the age of 5 and 6. Those who live longer suffer. They suffer throughout. So there's no need to have children who have sickle cells. We have been fortunate here that a lot of us have been faring well, but it's also Russian roulette if we don't continue start checking. Thank you.
Yes. Yeah. Thank you so much, Dr. Mercy. So I'll go to Ebere Aladi and then Dr. Julia. Is Ebere able to? If not, Dr. Julia, you can go next.
Okay, thank you so much, North Carolina. This is Dr. Goji here from DMV. Thank you. Great presentations, very insightful from Dr. Nneka and Sister Nnenna. Thank you so much. I have a comment. I'm glad Dr. Eke spoke before I made my comment. She said that this program is in collaboration with your local church and then Northern California. To respond to Dr. Obinna's question, with advocacy, especially with the population, people that look like me and you here, you take it to them. If you're collaborating with the church, maybe after church today, thank God you guys are doing it on a Sunday, you probably will speak to the people that really, we all need this information, but more people that need the information than probably all of us here are nurses in the healthcare. We have, basic knowledge of, this information. Like Dr. Bina said, people that are not in the healthcare, we see them more in the community, both of you concluded by saying knowledge is power. How do we get the knowledge? It's through information. Now we are talking to us here. The people, probably many of them are not here to hear this information. So there's no error right here. With advocacy, you take it to them, meet them where they are. And our people, we are a little stubborn. I'm not gonna generalize very stubborn. We are a little stubborn when we come to healthcare access. Despite we live in a country that a lot of us have the access to healthcare. And Dr. Ebujo, you took it from me about the sickle cell. Sister Nnenna presented detailed, great information. Again, she shared her information about how she got married. Probably many of us were in that same boat. We didn't have that information to go and ask, but now we do. Our children are dating. I tell my children, if she's good to be a boyfriend or a girlfriend, she better be good for marriage, right? So you don't come and tell me, there's no mistake in the marriage, there's no emergency. My son wedded December last year. We sat down and had this conversation. I know we have problem with communication, our community, but it's time we need to have this uncomfortable conversations, being comfortable, having uncomfortable discussions that the long-term goal, depending on how we navigate it, will be good or bad. Again, great presentations from both of you. Thank you.
Thank you, Dr. Julia. Ebere, are you able to speak now?
She actually posted her question.
Oh, she did. Okay, perfect.
Which is directed to me. So I'll read it. She said, a question
Okay.
to Mom, when you were in the ER as a light-skinned woman, did you expect to receive less discrimination compared to a darker-skinned woman? The answer is no. I expect to be treated as a person, as a human being when I'm in the hospital, regardless of my education or my skin color. Sadly, we all don't have the last name Smith. I encounter the same thing at different times, both in academia when I'm teaching. So there's that notion that because your last name is not Smith, a portion of your brain is not functioning, right? Same thing when you go to the hospital. So I don't think there's any difference between a light-skinned person and a dark-skinned person. Bottom line is that we're all Blacks, and unfortunately, we get to experience these biases when we go to seek care from healthcare providers.
Thank you, Dr. Nneka, for answering that question. And then I see Lola Fidelia, your hands are up.
Hello?
Hello, we can hear you.
Yeah, thank you, Dr. Nneka and Mrs. Ofoegbu. I have one question for Dr. Nneka and Mrs. Ofoegbu. So for Nneka, I have the question I have for you is I noted that Black people tend to have complications than other races. Why is that?
Nneka, you're muted.
Oh, thank you. You will think that since we've been using Zoom for a long time, we'll figure this out. But anyway, thank you for pointing that out. So Lola Fidelia, what I was saying while I was muted is that, implicit bias is a factor, a major contributing factor to the outcomes that we have. Anybody can have complications during childbirth, but what makes it even more pronounced for the Black woman or Black women in general is that there are components of implicit bias that affect the way providers manage our care. They're quite dismissive when it comes to us. You hear things like Black people can't tolerate pain. She's drug scared. I mean, there are a lot of misconceptions out there that impact the way providers take care of us, our nurses, doctors, etc. And so our goal is to know that one, implicit bias is real. We cannot continue to be in denial. And most importantly, we need to make sure that we're asking the right questions. Don't allow your voice to be silenced. Hopefully I answered your question, Lola Fidelia.
Okay, yes.
Great. Thank you, Dr. Nneka. I also wanted to add, sorry, Lola Fidelia, did you have a follow-up question?
Yes, I have a question for Mrs. Nnenna.
Go ahead.
Yeah, for this sickle cell disease, I don't know, maybe it's a superstitious belief also. They said that for the sickle cell disease, if during their struggling, if they did not die at the age of 18, then after 18, their struggle will be lessened than when they were young, when they were during their child age. So, and then for female, the death will face them during childbearing. Is that true?
Okay, so I think that I will say that would be a myth, that when you get to certain age and you're alive, it will the burden and the weight of the disease will be lessened. It all depends on each person, the severity, the frequency of the crisis will all determine how the body is able to cope when serious infection when serious infection happens. And for female, it's actually advised that they did not get pregnant because of the stress pregnancy puts on the body. It will require oxygen demand, and which causes more sickling. When the body is starved of oxygen or have certain kind of activity, the body sickling tend to happen more often. And plus they do have low blood level. Mm-hmm. That's one of the things chronic with sickle cell patients. They tend to have low blood level. With pregnancy, low blood level anemia can be also a problem.
Okay.
Yeah. And also, I wanted to go back to a question I answered earlier. The risk of marrying a couple with ASAS, you may say, there is chances. I came across a family of 4 boys and daughter, all came out with SS. And they're all having severe symptoms and crisis. You could end up with AS, it could end up with SS. That's the danger of having two persons with AS marrying. That's the danger. Okay. I hope I answered your question.
Okay. Yes, you. I believe she did. If not, we would have heard her say more. So I see Mrs. Nkiru Okeke, your hands are up. You're next.
Hello, everyone.
Hello.
Yeah, just want to say thank you for our great presenters. I really enjoyed the topics. My question is for a sickle cell presentation. So as a bedside nurse, what do you tell a teenage patient who is admitted in the hospital for sickle cell pain crisis and being with analgesic like morphine PCA, pain plan for oxy and all those heavy medications? And at the same time, this patient is refusing to take prescribed medication because he or she is feared, labeled as frequent flyers and seeking medications. What do you tell that teenage patient to be able to help him cope with his crisis? Thank you.
Okay, so lots of people with sickle cell condition, they have gone through a lot of crisis, a lot of pain, different kinds of symptoms during their young age. They tend to end up having a lot of psychological damage. anxiety, depression. When somebody is depressed, you could possibly notice that the signs with refusing care, with doing what we call, non-compliance. Probably I will ask the patient if they have gone through, or if they are going through any counseling. They can be possibly going through some depression. That's why they're refusing care. They just have to look for little control in their life. And that control is to tell you what they want, how they want. They do not want you to tell them what to do. So I will refer the patient to social work.
Great, thank you for that response. Okay, we have Dr. Angela Ikeme. You're up next.
Hello, thank you, Dr. Nneka and Mrs. Nnenna for such a wonderful presentations this evening. And thank you, Nigerian Igbo Catholic Community of San Jose and the Nnenna for collaborating for this. I think for Dr. Nneka, on your presentation on the maternal child, for an African American woman, a lot of the times when, even after the delivery of the baby, some of the women still go home with some postpartum symptoms. Say, for instance, the blood pressure is still high, the glucose is still high. What advice would you give these women who had these complications during pregnancy, postpartum? How would they take care of themselves, and what would they watch out when they are home with the babies, especially the first few weeks after delivery?
Great question, Dr. Angela. So we have, and I'm hoping that every hospital has a process of educating their postpartum patients on the signs to look out for, right? So high blood pressure is one of those. Severe headache is one of them. Epigastric pain. And also, for moms who have a C-section, they need to look out for signs and symptoms of infections, etc. Now, no one should be discharged from the hospital if their pressures are out of range, right? If they're hypertensive. And so this is where advocating for ourselves comes to play. It's okay for a patient to say, I am not comfortable being discharged from the hospital, right? It's okay to say that. It's okay to say, can I get a second opinion? And in some cases, quite frankly, I have asked patients to exaggerate their symptoms just so they can be seen by their providers. But in summary, what I would recommend is if the nurses check your blood pressure or any of your vital signs and they say, oh, this is abnormal or out of range, the patient needs to speak up, right? We discharge our patients home if they have normal vaginal delivery without complications after 2 days. But they can stay longer than that if they experience complications during the pregnancy or after they deliver their baby. So at the end of the day, we need to make sure that our patients are using their voices. Our Black mothers are using their voices to speak up when it doesn't feel right. And also using the ER when appropriate. A few weeks ago, I had a patient call the unit. She'd already delivered her baby and her blood pressure was very high. And so I told her to come to the ER right away. First, we made sure that there was somebody with her and someone who could drive her to the ER, otherwise call 911. And so we need to continue to educate our patients. And also we need to educate our ED staff, because again, that's all, that misunderstanding that once you've had the baby, you're out of the danger zone. And we know that's not true. So we need to also educate our ED staff. When our postpartum patients present to the ED, they need to expedite the process. They need to get the OB team involved to make sure that we're triaging the patient the way we're supposed to, and they're receiving appropriate care, because they can stroke out, right? And they can die from severe range high blood pressure.
Thank you for that
Yeah.
response. Dr. Angela, did that answer your question?
Yes, thank you, Dr. Nneka. Thank you, Dr. Ngozi.
You're welcome. I know there's a question in the chat, but I see your hands are up, Dr. Agatha. You're on mute.
Okay. The question says, is sickle cell disease more in Black race than other race?
I'm sorry. I think Dr. AK is having difficulties unmuting herself. She was speaking and
Okay, now.
there you go. Okay.
I think the host was mute. So I just wanted to speak to the person that asked the question about the teenager who is having pain and refusing to take the medication. So our teenage age, our young adults, they're looking for an ally. Okay, so the best way, in my experience, because in my practice, I have encountered somebody who experienced sickle cell crisis. Yes, they do receive a very large amount of drugs. So our teenagers need allies, and in the area of really educating them about what's going on with their system in order to take away the stigma from, oh, it's you seeking drug. No, like Nnenna pointed out, if we educate them to the fact that the blood cells are not functioning properly as they are supposed to, and as a result, the pain is there, and that taking the pain medication is to ameliorate that process until it passes. If we take it away from the fact that it's them requesting pain medication and helping them to understand that the pathophysiology and function of the body is sort of not how it's supposed to be at the moment, which is what is causing the pain, that goes a long way to give them control, because now they are a little bit informed than just a patient in room 2 who is looking for pain medication, kind of. They are looking for an ally, to somebody to make them feel like they are understood in what they are feeling. So that's a good way and that takes time. And I know in the hospital we are running to take care of many people, but this is the one time you can sit down with them and really educate them what's going on, and I reassure them that it's okay that for them to take this pain medication in order to, manage what's going on. Thank you.
Thank you. So we're going to be rounding up. And I know I saw Dr. Mercy, your hands were up again, but Dr. Bina, gonna give us the closing remarks.
Thank you so much. I'm overwhelmed. Thank you so much. And this is really getting 2 for the price of 1. Thank you so much. Thanks to Dr. Nneka Chukwu. Thanks to Mrs. Nnenna Ofoegbu. And thanks to my co-organizers, Dr. Biro, Dr. Eke, thank you so much. We've been going back and forth in preparation for this. Dr. Oyuwogu, thank you so much. And thanks to our to NOCAL. Your association is amazing. This is the kind of thing we're looking for. And thanks to our Igbo Catholic community. thanks to everybody that participated in this. It's been really educating. I've learned a lot myself. So I think we have to end it at this point, and we'll end it with a short prayer. I don't know if there's anybody we can appoint to say the prayer for us. Okay, Dr. Ada Jesus, can you say a closing prayer for us?
Oh, thank you, everyone. Oh, thank you to our two wonderful presenters, Dr. Nneka and Mrs. Ofoegbu. Thank you. So let us quiet ourselves, recognizing that we're constantly in God's presence as we conclude tonight. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Good and gracious God, we just want to say thank you so much for your love. Thank you for your blessings. Thank you for the grace that you have granted us this evening to hear all these wonderful topics from our presenters. We pray that you strengthen us, that you give us all the knowledge and wisdom that we need to be able to advocate for ourselves and for our siblings and for all the members of our community. We ask that as we go about doing our duties this week, that you bless us and bless our families. All this we ask through Christ our Lord. Amen. In the name of the Father, and of the Son, and of the Holy Spirit.